Good afternoon, ladies and gentlemen, and welcome. It's been some time since I stood up here introducing people, but my name's Dr. Roy Clegg. I'm a retired consultant physician rheumatologist many years ago and was the predecessor as Director of Medical Education to Adrian, who took over from me about 6 years ago. Adrian sends his apologies, but he's on the important study leave today. It gives me the opportunity, however, and I think I'd like to just say a few words, that I'd like to congratulate him and as to what he's done in the last 4 to 6 years with the building of the Medical Education Centre, as well as forming a great team around him, which has greatly enhanced the education facilities for our trainee and senior doctors. So he's done a brilliant job, and I hope he'll continue to undertake that job for some time into the future. I'm the chairman of still the chairman of the Isle of Man Medical Research Committee, and today's topic is based largely around some research funded by the Isle of Man Medical Research Committee. Our speaker today is Dr. Becky Rowley, who qualified as a BSc Honours in Public Health, going on to gain a PhD in Health Sociology and Primary Care Science at Keyll University in 2016. Now, her thesis, ironically, in fact, was to do with arthritis, considering my interest in arthritis and rheumatology, and her external assessor for her PhD was actually a previous medical rheumatology trainee of mine when I was a consultant in Manchester. So it's a small world. Also a small world is the fact that Rebecca is Manx born like myself. She's an honorary fellow at the University of Liverpool, dissertation supervisor at Isle of Man University College, and a sociology tutor. But more recently, she's been appointed as the first operational lead for research and development at the DHSC. So I'm glad to ask Becky to come and give a talk today, and you'll see that her title is on the screen. So thank you for coming.
Thank you. Sorry, I just saw another microphone. I can't use technology, obviously. So thank you very much for that kind introduction. My talk today is entitled Actions Have Consequences, exploring doctor-patient interaction with women pre- and post-abortion. So first of all, just a little bit of an overview of the current situation on the Isle of Man. Abortion is legal on the Isle of Man, but inaccessible. It's governed by the 1995 Medical Defences Act. Because of the restrictions of this Act, it means that in practice, fewer than 10 women per year access an abortion on Ireland. This means that most women that need an abortion have to either travel to the UK and get one privately, or order a legal abortion medication over the internet and do a home abortion themselves. Because both these practices fall outside the current legislation, there's very few statistics which tell us how many women per year access an abortion on the Isle of Man. We know that currently approximately 100 women per year travel to the UK and give an Isle of Man postcode. But the problem with this statistic is that very few women actually do give an Isle of Man postcode. We know that people lie about their postcodes when they access private abortion. Equally, illegal abortions also fall outside this legislation. We know that in 2016, 10 packages were detained by customs containing illegal abortion medication. But equally, we also know that many women did actually receive this medication. Because of this lack of information, we don't actually know how many women on the Isle of Man access an abortion each year. There's generally very little research conducted on the Isle of Man into unintended pregnancy or abortion. One of the only studies that's been conducted was part of the ELSPAC study, which is a longitudinal piece of research conducted between 1990 and 2007. It looked at many things, but one of the things was unintentional pregnancy. It found that on the Isle of Man, unintentional pregnancy was very, very high, and that women on the Isle of Man were 8 times more likely to commit suicide during pregnancy compared with Avon in the UK. This was prior to the introduction of the 1995 Act. So I wanted to undertake this research to understand what effect, if any, the current legislation has on women from the Isle of Man. Evidence from other countries suggests it is likely it does have an effect. In Mexico, abortion is illegal, and it's found that women that undergo an abortion in Mexico have high negative psychological consequences. It was found that it was the clandestine nature of the abortion rather than the act of having an abortion itself which led to these effects. In Mexico, it was the dominant Catholic doctrine and also the illegal nature of the act that meant that women internalised the stigma from society. These effects were also found across Latin America and in Nigeria, Pakistan and Peru. And the problem is that when we restrict access to abortion, this risks women's emotional, mental and physical health. And as access to abortion on the Isle of Man is so heavily restricted, all of these risks are likely to affect women from the Isle of Man also. So in order to be able to understand this study, in order to be able to undertake this study, I conducted 8 interviews with women from the Isle of Man that had an abortion within the last 10 years. The interviews lasted on average about 2 hours each. I then transcribed the audio recording and analysed the interviews using a combination of thematic and narrative analyses. Although I won't talk about it too much today, I also undertaken a media study. And the reason I want to do this is because I really felt that what I'd heard from the women was that society had a really big impact on how they felt about their own abortion, and the media probably played a large part in that effect. So to be able to do this, I searched all newspapers in the Isle of Man for the last 10 years, and I retrieved 30 articles that mentioned the word abortion. I analysed these using critical discourse analysis. All the women in the interviews talked about their experiences of healthcare at different stages. And today I'm going to focus on 3 stages which they mentioned: pre-abortion, during abortion, and post-abortion care. First of all, pre-abortion. So one of the big factors that women talked about was where on earth can women from the Isle of Man find out information about abortion? And this seemed to be a big problem for lots of the women. So there's very little in terms of sex education which mentions abortion on the Isle of Man. 2 of the women in my study were actually 17 when they found out they were pregnant, so sex education was fairly recent for them, and yet neither could remember any instances where abortion was mentioned in their sex education. They also mentioned concern about religious groups perhaps having an involvement in sex education on the Isle of Man, and they felt that this would reduce the likelihood that abortion was mentioned. There's also no mention of abortion in family planning literature on Ireland, which means that even if a woman does qualify for an abortion on the Isle of Man, she's unlikely to know about this, as generally it's assumed that abortion is actually illegal over here, which means that women who would otherwise qualify do actually travel for private abortions. And finally, although there's an increasing amount of information now on the internet, at the time when many of these women were looking, there was absolutely no information. One woman described this as an information black hole. So although abortion generally is covered on the internet, abortion in relation to women from the Isle of Man, there's nothing. This left many women really confused about where to go, and therefore many consulted their GP when they found out they were pregnant because they didn't know how to access an abortion. So why do women consult their GP when they find out they're pregnant? Many women access GP consultation because they're unaware of current restrictions. So some of the women in my sample thought that they could actually access an abortion through consulting their GP because they thought that the law in the Isle of Man was very similar to the law in the UK, and it was only during this consultation they realised this wasn't the case. Some women wanted more information about their options, so they kind of got this shock: yeah, okay, I'm pregnant, I don't want to be, what do I do now? Some wanted their pregnancy confirmed. So some women, this was their first pregnancy, they didn't know how effective pregnancy tests were, like how good is a home pregnancy test, am I actually pregnant? So they went to their GP to make sure and get it confirmed by a medical professional. Some women thought that their GP would be able to provide information and advice about how to access an abortion and what the next steps for this are. Some want to talk to somebody in what is a very difficult time. Finding out you're pregnant when you don't want to be, it's incredibly stressful. And often women, because of the stigma of abortion, they didn't have anyone else to talk to, so the GP provided some kind of confidential advice for them and somewhere to go. Finally, the overriding feeling was that women felt that going to the GP when they found out they're pregnant just made sense. As one woman said, yeah, I certainly had a moment of, what do I do? But then I thought, be sensible, go to the doctors, this is a body thing, and that's what you do with your body, you take it to the doctors. Women's experience of GP consultations had much variation. One woman found the experience incredibly negative. She thought her GP was judgmental and condescending. However, another woman conversely felt the experience was incredibly positive. She thought her GP was supportive, helpful and non-judgmental. However, the majority of women simply found their GP to be unhelpful. They thought they lacked engagement and didn't give them any information and advice about what to do next. The woman who found her GP judgmental and condescending says, "I remember going to the doctors and the doctor saying to me, 'Well, actions have consequences.' I very much felt like that. I felt it was something that I had done." This woman felt that her GP had a moralising attitude, that she was not supportive of her decision and was judgmental about her circumstances. And this meant that the woman felt the GP did not agree with abortion. Most women, as I said, just received a lack of engagement, information and advice from that first consultation with their GP. Emma says, "My GP said you do have options, however we can't help you over here." She actually wrote down, I think it was VPAS and another one, on a post-it note and gave it to me. That was it. That was all I was given, was a post-it note. And you know when you think, I know you can't help me, but a post-it note is not the way. This is not how you deal. This immediately made it feel a little bit grubby. So in Emma's circumstance, she kind of felt like, well, the GP was kind of washing the hands of her. Here's a post-it note, sort it out yourself. This was backed up by Michelle's experience. Michelle says, "My GP said there was nothing I can, like if they've all come back positive, then you're definitely pregnant. There's nothing I can do about it. He just assumed that I would not want to come, he just assumed that I'd want to come back for an antenatal appointment. So I said I don't want to keep it and he said, oh. I don't even remember he gave me a leaflet, to be honest, but the Mary Stopes clinic was mentioned. He just said you have to book it." So in this case, Michelle's GP assumed that she would want to keep the baby. So therefore he started straight away booking her into an antenatal appointment without even considering that she might want to explore other options. She felt that as soon as she mentioned about the fact that she wanted an abortion, that the GP consultation was just shut down from that point. They couldn't talk about anything further. It was very much, you go away then, we can't help you. This lack of information and advice meant that women felt that they were alone, both in making the decision to have an abortion and also making the practical arrangements to do so. This left them feeling unsupported, unprepared and isolated. As Abigail said, "I felt totally alone. I thought I need to organise this termination, but there is just nobody and nothing." And that was just terrifying. However, this isn't the experience for everybody. One woman in my sample, as I said, had an extremely positive experience with their GP. She said the doctor, they off the record, gave me contact details for people that could help me if I chose to go down the abortion route. And that doctor was, very, very supportive. If I would have gone to another doctor, I would have just been told, well, there's nothing we can do, you sort it out yourself, basically. She felt that her GP supported her decision and that they provided advice about options for an abortion. It's really important to recognise that she felt that this was about her specific doctor. She had friends that had also went to the GP when they needed an abortion and had been told as well, sort it out yourself. So she felt incredibly lucky to have this consultation with her GP. She also felt that the doctor had to go off record in order to be able to give any information and advice about abortion. And during our interview, she was incredibly concerned about not revealing the GP's identity because she wanted to protect her about this issue. She felt like the GP was going out of the kind of guidance on the Isle of Man by doing this. So women consult their GP when they suspect that they're pregnant for a number of reasons. Discussing a woman's feelings about their pregnancy can help GPs to determine what women want. It should not be assumed that a woman, just because she's pregnant, necessarily wants to keep that pregnancy. And just because abortion is not readily available in the Isle of Man, it doesn't mean that she doesn't want to access one. GMC guidance states that the doctors are required to provide advice on accessing abortion to women or refer to the patient to a doctor that will. The evidence in this study suggests that this is currently not happening on the Isle of Man. Only one GP provided any information or advice to any of the women in my study about what to do next. Providing advice and support to women is not contravening the Manx law. So unlike the woman that thought it was, it's not. It's not going against anything that we currently have on the island. Just because you cannot provide an abortion doesn't mean you can't talk about it with the woman and explore her options. It's important that GPs are supportive, free from judgment and helpful, because this means that women's decisions are validated, supported, and it reduces stigma. It makes a very difficult process much easier for women. During abortion, And I know that abortion is quite rare on the Isle of Man at the moment, so perhaps this isn't quite so useful, but I felt there's some really important lessons that can be taken about how we treat women who are consulting for an abortion on the Isle of Man from their interactions with healthcare professionals in clinics in the UK. One of the important things for women was time. They were given time to think about what it was that they wanted to do, and they didn't feel rushed throughout the consultation. Discussions were led by women. They felt this was really important because they could determine what it was that they wanted. They felt that they had options and choices. Also, clinics use the same language that the women use, and this is really important. If you mimic a woman's language, it kind of makes her feel validated in what it is she's saying. Clear information was given. A lot of women, if they've never experienced it before and they haven't had anyone else that's experienced it, knows nothing about abortion. Most women don't know the difference between medical and surgical abortion. They don't even know there's different options. Because abortion is not discussed, people don't know what to expect with an abortion. They don't know what to expect afterwards, during, or even when to access follow-up healthcare. So it's really important that the clinics gave really clear information. The role of the partner was mentioned by a lot of women. Partners aren't always allowed into abortion clinics, and there's very good reasons for that in terms of making sure that women aren't being coerced into that decision. However, once it's been established that a woman isn't being coerced, it's important to allow her to have a support network with her. And because a woman was away from home, she felt it very difficult when the partner was banned from the clinic. I think on the island, we can kind of take into consideration the role of the partner, even in GP consultations about abortion. Women experience complex emotions, and it was felt that the clinics all recognise this. Just because a woman is emotional about a decision, it doesn't mean that she's uncertain. Women experience a whole range of emotions around abortion, including things like grief, shame, loneliness, but it doesn't mean that she's any less certain in what it is that she wants to do. The women liked being treated like individuals. Once again, when they were able to be treated like a person, they felt that they were in control. And being in control is incredibly important because they're already massively out of control in terms of their pregnancy. They don't want to be pregnant than they are. So giving them back an element of control was felt to be very important for women. And finally, and I know it's really obvious, but kindness. Because the clinics treated women with kindness, they felt really supported and validated. And this was something that an awful lot of them didn't receive in their GP consultations. Post-abortion. A range of healthcare professionals may come into contact with women post-abortion. Within my sample alone, women came into contact with GPs, nurses, mental health services, gynecology, A&E and surgical staff. In my sample, 3 women required follow-up healthcare following their abortion. And I recognise this is an incredibly high rate in comparison to kind of UK statistics, because abortion is a very safe procedure, follow-up healthcare isn't normally needed. But on the Isle of Man, I think there's specific reasons why women may need follow-up healthcare. The first reason is delayed treatment. So one woman in my sample had to delay her abortion by 6 weeks because she couldn't get access to funds, firstly, and also she was only 17, so she needed to actually get a passport for the first time, which she'd never had. So all these factors meant that she had to delay her treatment. By the time she managed to access an abortion, she needed a more invasive surgery, which has higher risks of complications, and she did actually experience complications afterwards. And the second reason, I think, is uncertainty after illegal home abortion. So when women aren't going through proper channels to get an abortion and they're just ordering tablets off the internet, there is less support there. They don't know what to expect afterwards, which may mean that they're uncertain. That's not to say that home abortions are necessarily risky. A lot of studies have been conducted which have found that actually they're incredibly safe usually. But I think this is more speaks about the need for support rather than the medical complications of it. So one woman experienced complications following an illegal abortion, and although she generally had a really good relationship with her own GP, she felt unable to disclose the fact that she'd had an abortion due to shame and a fear of prosecution. So Louise said, "I did go and see my GP, and I told her I'd had a miscarriage. Well, I just didn't think. I don't know. I don't suppose. I don't feel like I could say I just didn't feel comfortable that I could say what I'd done. I don't think at that point that I needed to say that I'd had an abortion. Because I know you kind of probably, in theory, you could get into trouble for it. I don't think you would, but I don't know. I don't suppose, you feel ashamed about it." So this woman had ordered tablets off the internet, taken them at home, had a home abortion. She was actually incredibly well informed about the whole process. However, she still felt afterwards that she needed that reassurance that everything was okay. She didn't have a period for a little while afterwards and she didn't know if that was normal, but she still felt unable to tell anyone what it was that she'd done. Although she knew that prosecution was very unlikely, she still feared it, and that meant that she just didn't want to talk to her GP about it. A second woman experienced complications following a surgical abortion and required secondary care. She disclosed her abortion to her GP in order to develop access follow-up care with a gynaecologist. She felt her GP was judgmental of her circumstances and did not support abortion. She said, "Oh, they kind of like, well, she's just some teenager who got pregnant and got rid of it," which is a very cynical, low opinion of the profession. I'm sure the overwhelming concern is the patient. However, I did sort of feel like that with her. I did feel that with the GP. I don't think she supports abortion at all. Because of how the GP left this woman feeling, she felt she could not go back and speak to her GP again about the fact she'd had an abortion. She felt like she was being judged. This girl was only 17 when she had an abortion, and she felt like because of that, the GP was judging her own circumstances about why she needed to access an abortion. The third woman also had an illegal abortion, but she felt able to confide in her GP. This was really positive for her because they managed to discuss the treatment. Her GP then could provide ongoing support and advice throughout, and she signposted to counselling afterwards. She said, "I'm so glad I had a doctor who would actually discuss these things with me." And yeah, the doctor was amazing. The doctor was just amazing, like. Not just from that appointment, she helped me all the way through until after when I went to counselling. And yeah, I could call her up and she would discuss things. Yeah, it was amazing. So for this woman, it really shows you the positive impact that a good GP consultation can have on women. If they feel supported in their decision, although this whole situation for Charlotte was incredibly difficult, she had a lot of complications, the relationship with her GP really got through that. 2 women in my sample required follow-up treatment and secondary care. However, neither had a good experience of secondary care. The first disclosed her abortion to her consultant, but felt she was dismissed, so she had to access gynecology. She said, "I had like a really awful consultation with this gynecologist. I said, I've got this lump. He examined me, and I remember the examination being really painful because the lump was really painful, and so I was quite upset. He referred to my termination throughout this consultation as a miscarriage. Then he told me that my contraceptives weren't actually contraceptives. I remember him telling me, you might need to take a pregnancy test. In this consultation, that was a couple or a few months after a termination, and I was hysterical. I was really completely hysterical. I still didn't know what the lump was. I still didn't know. All I knew was I had a painful consultation. I was really upset, and I was just crying on the bus, I don't know what's wrong with me. I don't know if I'll ever be able to have sex again. I don't know if he says I'm pregnant. Do I need to take a pregnancy test?" So this consultation with the gynecologist for this woman was incredibly traumatic. She didn't actually get any follow-up care after this, so after she went home, she still didn't know what the lump was, but she never went back to see a gynecologist. She kind of just hoped it would go away, which it did after 6 months. But during this time, she was unable to have sex, which then had a massive impact on her relationship with her partner. She did also take a pregnancy test, but even the fact that they'd mentioned that she could be pregnant after an incredibly traumatic abortion, she felt the whole thing was really, really difficult for her, and she didn't feel it was handled well by the gynecologist. The second woman had retained products of conception following her illegal home abortion, but she couldn't disclose this in secondary care due to fear of prosecution and fear of her abusive partner finding out. So when she consulted in secondary care, she was with her partner, but he was abusive, and that was the reason behind her abortion. So she couldn't say anything for those 2 reasons, really. She thought that she'd go to prison if she did, and that if her partner found out, then they had an incredibly difficult relationship, and that would make things really hard for her. So she said, "I ended up having another 2 lots of tablets. I had to have that because I couldn't tell them what I'd actually done. If there was that option, I might not have had to go through the further 2 lots of tablets in the D&C. I was like, if I could explain to you, maybe I wouldn't actually have these tablets that you're offering me. I'm actually safe to have more tablets when I've already had tablets, but I can't tell you." So Charlotte really didn't understand what it was happening to her. She knew she'd already had the abortion medication pills, which she took by herself. She didn't know she was safe to take any more, which was what they were offering her. But she couldn't tell them. She thought that by taking these tablets, she was actually risking her physical health. She didn't know what was going to happen to her. But despite this intense fear, she still didn't say anything. And I think this just shows how strong the fear of prosecution is around women around illegal abortion. So women experience negative interactions with healthcare professionals, whether they disclose their abortions or not. When women do disclose abortions, it's important to use the same language as women. If they refer to a termination, refer to a termination. The reason this is important is because the language makes women feel validated in their decisions. It means that you're talking to them on their level. It's important not to misclassify an abortion as a miscarriage. In this case, it made a woman feel really invalidated in her decision and judged for it. It's important to recognise that women may have physical and emotional difficulties following abortion. They may be extra sensitive to things like the idea that they might be pregnant again in future. And if a woman doesn't disclose, for which there are many reasons, we need to recognise that women may misclassify their abortion as a miscarriage. We need to understand that women may fear prosecution and/or judgment for that disclosure. We need to reassure women, when it's appropriate to do so, that they will not be prosecuted for their actions. And we need to not make assumptions and be supportive of women and led by them. On the Isle of Man, abortion stigma is incredibly important in this process. Abortion on the Isle of Man is seen as a political and moral topic, which means that it's generally removed from healthcare. It's presented as a dichotomy, something either people are for or they're against. This means that women's experiences are largely ignored. It's also represented as inevitably controversial. This means that abortion is not normalised on the Isle of Man, and it's very, very difficult to normalise it. This leads to higher rates of negative psychological effects for women, and increases the stigma, shame and secrecy that they experience. It's important to recognise secrecy in abortion because it relates to the prevalence paradox. This means that women underreport and misclassify their abortions. Therefore, abortion is thought to be uncommon on the Isle of Man. Abortion is therefore seen as deviant and not socially accepted. This means that women who have abortions face discrimination. Therefore, they fear stigmatisation for having an abortion, which once again leads them to underreport and misclassify. It's this process of the prevalence paradox that means that on the Isle of Man we think abortion is quite rare, whereas there's no evidence to suggest that rates of abortion on the Isle of Man are very different to the UK, in which 1 in 3 women has an abortion within their reproductive lifetime. So in fact, abortion is probably incredibly common on the island. We just don't collect these statistics, so we don't know. Women reported mental health effects as a result of their abortion experience, including anxiety and depression. As abortion is not routinely provided, they did not know where to access help. On the Isle of Man, there's no specific counselling or advice services to help women, either pre or post-abortion. This leads to increased negative psychological effects for women, but this is not inevitable. It's caused specifically by the environment on the Isle of Man. In the UK, there is no significant difference between women who have abortion and who continue pregnancy in terms of negative psychological effects. Therefore, we can change this by treating abortion as a normal part of women's reproductive health care. In conclusion, abortion is rare on the Isle of Man, but many healthcare professionals will still come into contact with women who haven't had an abortion. Abortion is highly stigmatised on the island and cloaked in secrecy. Interactions with healthcare professionals have a large impact on women's experience of abortion, both before, during and after. Healthcare professionals can work to either reinforce or demolish stigma and shame. We can help women who have had an abortion by listening, being non-judgmental, not making assumptions, providing information, and most of all being kind. Abortion is a normal part of women's reproductive health care. Let's treat it as such. I'd just like to say some quick thank yous. Thank you to Professor Mary Fox at the School of Law and Social Justice at Liverpool University. Thank you to the Isle of Man Medical Research Committee for funding this research. And most of all, thank you to my participants, without whom this research would not be possible. And thank you to all for listening. Any questions?
Hi Becky.
Oh, sorry.
No, can we have... No. Sorry, we start at the front, sorry. Don't get that on.
Important first.
I saw a hand first.
Becky, that was a fantastic presentation
Thank
and a great research study, so thank you very much. It was very interesting to see that your participants were very aware whether the GPs were judgmental or not.
Yes.
Because that shouldn't come into it at all, whether they approved of somebody having an abortion. So that was just the first point. But how did you reassure your participants that they wouldn't be prosecuted to get them on board?
To be able to do the study?
Yeah.
It was actually quite difficult because when you're doing research, then, you know, there's lots of times that you research topics which are illegal, particularly, a health sociologist, so that's quite normal, it's quite a normal experience. But trying to reassure people in a small community that they will not be prosecuted or that it'll never go any further was incredibly difficult, and something that actually was raised quite a lot in ethical conversations with the ethics committee and stuff. Basically, I took on the position of complete confidentiality, which means there's no limits to it. Basically, within the law, you, as a researcher, your information is only useful if you actually can do something with it. So I took the position that when women contact me, they didn't have to give me their real names. This meant that by giving pseudonyms, I didn't actually know who they were, and also it was only hearsay in terms of the fact that they were reporting illegal behaviour. And I was able to give that reassurance, therefore, to women that even if I was subpoenaed, which is incredibly unlikely, but even if I was, I would have absolutely no useful information to be able to give the police. However, as a personal note, it would never even be the case. As a researcher, confidentiality is the most important thing to me, and reassuring the people in my study that this was the case was just really important. So it was emphasised at every single stage, and women were able to withdraw whenever they wanted, and also if they wanted to be able to have a look over the quotes before I used anything, or if they said anything during the interview, which a few women did, say, actually no, please take that out of the recording, I did and just didn't transcribe it. So I felt it was really important to give women the control over that process, I guess. Thank you.
Darree?
Do we know how many ladies are prosecuted per year for abortion?
On the Isle of Man, none. Yeah, none. So nobody's ever been prosecuted within recent years that I'm aware of anyway for obtaining illegal medication. We know it happens, but there's absolutely no appetite for prosecution. It doesn't mean that it won't happen in future. I would hope it never would, but there seems to be no appetite for prosecution.
So shouldn't the law be changed then and make it legal then?
It's a very good question. I agree, yes.
Right. Mr. Ghosh.
Yeah, thank you very much for your presentation.
Thank
I have
you.
2 questions. In your research, did you compare anything with the Northern Ireland? Because you are comparing with UK.
Mhm.
Situation in Isle of Man is not like UK.
Mhm.
So sometimes comparison in Northern Ireland could have been better. But the second question is, you mentioned about all those things about GP and secondary care. You haven't touched at all about the public health responsibility in Isle of Man with your research and what they should do.
Okay, thank you. So to address the first question first, which was about the comparison between UK and Northern Ireland. So I used the UK mostly because most of the women in the study accessed abortion healthcare in the UK, so it felt quite close to the study, I guess. I have looked at Northern Ireland, although I haven't actually mentioned it in this presentation. The professor that I'm under at Liverpool University, that's her research area. She researches abortion in Northern Ireland, completely, that's what she does. So we've talked quite a lot about the similarities, and I know on the surface it looks like the situation on the Isle of Man is very similar to Northern Ireland, and in some ways it is, but in some ways it's very different. On the Isle of Man we don't actually have the same religious background that Northern Ireland has, so we haven't got this kind of religiosity, is that a word? And we haven't got that. So which that means that basically there are different drivers, I think, behind the restrictions on the Isle of Man than there are in Northern Ireland. Most of the stuff in Northern Ireland is about religion, and I think the internal shame that women experience in Northern Ireland is around that stuff too. So I think that the Isle of Man's actually quite unique in the world even, in terms of why we have restrictions on abortion. And I think that there's an awful lot more drivers behind that, and I think it'd actually be really interesting to do a study to unpick those things. I've got my own views, but probably, maybe I shouldn't say that. But anyway, I think that there needs to basically be some more research into that. And the second question was public health. Yeah, I think that there needs to be something done about this. I think the problem is for public health is because we have no statistics, we've got no evidence, we don't know actually what's going on. I think there's a big public health need for something to be done about this. I think this is the first study which has actually said no, there are negative effects. Personally, I think in the past people have thought that out of sight, out of mind for women. Women are going to the UK, they're okay. It's fine, they can get on the boat, they can get an abortion if they need one. Let's not worry about it. And I think that's been the Isle of Man's position on abortion generally. Not that it's massively against it, but it's kind of like not in my backyard. So I think that now that we know that there's negative impacts, I don't think it can be ignored from a public health perspective.
Because at least the school, the family planning clinic, and the information leaflet, they all come into the public service domain, don't they?
They do.
So they haven't done anything.
No, not yet. I'm hoping from this that people will do something. I think it's incredibly important that even if there's just some information, like it's ridiculous, you find yourself pregnant and you can't go anywhere for information. I think that's ludicrous, and I had no idea that was the situation in the island until I started looking at this. So yeah, I agree, I think something needs to be done, and hopefully it will be from now on.
Can I just ask? I mean, this is a quantitative study of a relatively small number of people.
Yeah.
Could there be a big bias there on that small number of people that came forward?
I do think there might be a bias. I mean, in qualitative, the bias isn't so important, I guess, because we are looking at small numbers. But I actually think that the situation might actually be worse. So the women that came forward to speak to me are likely to be the ones that are more able to talk about their abortion, that have less anxiety associated with it. I had people contact me saying, I want to take part, but I've got such bad anxiety following my abortion, I can't actually talk to you. So actually, I think our sample here probably presented a more positive view of what women's experiences are than actually reality. So I think if we could do a larger study, I actually think the picture might be more bleak.
Just two things. Where did you advertise, or how did you advertise?
So I advertise in a number of channels. I use social media. I did an interview on Max Radio. And I tried to contact the newspapers, they weren't keen on picking anything up with that. I contacted all the radio stations, only one actually picked up an interview. So it was actually quite difficult to advertise this study. A lot of people just didn't want to have anything to do with it. The contact I had about 35 women contact me, which is incredible. I wanted to interview 10, but because most women fell outside my criteria, I couldn't. Because I put a 10-year restriction on it to make sure that we had contemporary experiences, most women that wanted to talk to me couldn't for that reason.
Right, that was going to be my second question about access in secondary healthcare in regards to mental health.
Mm-hmm.
You know, if it's 10 years, you probably have an idea of people further down the line who might need mental health.
Yeah, we don't know. I know that the women in my study reported that they'd had anxiety following their abortion, that they'd had depression, and some had accessed mental health services. But I don't know about the kind of, I guess, longitudinal picture of that. I don't know how that looks going down the line. And again, I think we need research to be able to back that up on the island.
There's a question there.
Well, I think the Northern Irish experience that Karen was talking about and public health. Now, if you look at the Abortion Act in the UK, Northern Ireland, Scotland, or Ireland, if you aid and abet, you're in trouble. So the issue was if you actually cancel somebody about having an abortion, you aided and abetting and against the law. So in the North of Ireland for a long time, we couldn't cancel the girls or come out openly and say you're doing that or advertise. And I remember in 1998 when Mary Stokes opened in Belfast, they were surrounded by the only thing that unified the IRA and the UBF was abortion. And they went down to the clinic, and anyone who went through there went through hell. Now, but things have changed because the province decided to start a discourse on, termination of pregnancy, and that's what we need to do on the island. If you did a public health issue and come out with a leaflet saying this is this, you're actually going against the law as it stands. So we need that changed. And for a while on the island here, Bob, Mr. Phil, who's my colleague, had tried to be. Got in touch with the judicial setup here to see how we can change things and then move on from there. But the point we're at now is that we are actually having an open discussion regarding termination of pregnancy in the island, and that's it's a good thing as it is, because you see most of the girls coming back to the ward here with incomplete miscarriages, infections, and all that. So it's good with, that we started a discussion on it. But the Northern Irish experience should be an example of what would happen in the UK if we didn't do things. I mean, in Isle of Man, if we didn't really, take the proper steps to correct the situation here.
Yeah, I take your point there, and I agree. It's great that we're having a conversation about this. I think that this actual presentation, I don't think would have been possible a few years ago. To even talk about this would have been possible, and in doing this research, I've faced a number of blockers when I've been trying to talk publicly about this topic, so I do think there's still a lot of work to be done on that. I wasn't aware that on the island that if we gave advice to women that would be contravening the law in any way. And I might need to have a look into that, but I didn't think that was the case over here. I thought that legitimately public health could do a campaign at the moment saying this is how you can access a safe abortion, I guess. I mean, I know we can't advertise illegal abortions or anything like that, and I'm not saying we should, but I just think that giving some information to women is just incredibly important, just that basic information about what to do next, particularly if when they're consulting their GPs and the GPs are just shutting down that conversation. We need to have another route into women, I think. Thank you. Hi.
Can I just make a comment?
Yeah.
My name is Dr. Hannah. I did work in GP practice for some time, and according to NHS and GMC guideline, you as a doctor or professional, you're not going to be in a wrong situation if you give the pregnant lady any advice or the information that she needs and direct her toward the safest way to do the abortion if she wish. There is no anything that say you can't do that, and actually it is advisable to direct the woman to the right path if you can, and if you don't want to as a doctor because of your beliefs or religion background or whatever, you obliged to allocate another the patient to another doctor or another healthcare professional who can help the patient. This is the guideline about this issue, so nobody would be in wrong position at all from professional point of view to direct the ladies for the right path for this. And it's very well documented in General Medical Council as well, guidelines. And there is a very well-known website, NHS Choice. .co.uk, where there is termination of pregnancy is a big subject and big and it's very, very useful with lots of phone numbers and informing the ladies what can happen before, during and after the abortion. So it's a very useful website as well, and most GPs use it as well.
Yeah, thank you for that, and I agree. I do think GPs should be giving this information to women, and I agree it's going against the guidance by not telling women about what their options are or not referring them to another GP. And I think the reason that it's been going on in the Isle of Man for so long is simply because no one's ever questioned it. The GPs have been able to do this and also perhaps worried about their own position in doing it, their own position in terms of contravening the law, not being sure about that guidance, how it relates on the Isle of Man. But I agree, I think that GPs need to be giving information to women, and now that we know that that's not happening, we need to be doing something about that rather than just sitting there going, no, it's okay. Women are consulting and just literally getting shut down in terms of abortion conversations. So yeah, I agree. Thank you.
Right. Well, there's two more hands. We'll take those questions. Yes.
Do you not think if you'd have done this study in an 80,000 population in smaller places in Britain, you'd find the same thing?
I mean, in terms of the stigma stuff?
Yeah.
No, I don't actually. I think that I understand what you're saying, that small communities have increasing amounts of stigma, and I accept that completely. But I generally think in the UK, for instance, because abortion is accessible and it's not got this massive amount of secrecy around it, that I do think it's different. I think on the island, because it's so restricted in law, and because it's not talked about, and because women who are consulting with their GPs, they're not even being given any options, I think the stigma on the Isle of Man is more concentrated, which means that women are more likely to suffer the negative psychological effects. And I think it's a specific thing about when you restrict something, when you make it illegal, when you make it inaccessible, that has an impact on society. And I think the very fact that, when you're trying to talk about this, in the UK, if you give a talk on abortion, it's not a big deal. On Wednesday I tried to give a lecture on abortion. I got asked to change my title because apparently my title was too controversial because people don't want to be associated with the topic of abortion. So I do think there's this underlying stigma that's really hard to unpick on the Isle of Man, that I think that these conversations are hopefully going to start unpicking.
One at the back.
Going back to the question of GPs providing advice and support, I mean, they've grown up with the feeling that they're not supposed to.
Yeah.
Now, we can say they have a responsibility under GMC guidance to point someone in the direction of a colleague who might provide that support and advice. But you're dealing with a closed community where there may not actually be a great number of people who are prepared to take on that role. And it's going to take a whole generation of new GPs coming through to change that. So how are public health going to address that in the interim? Is there an argument for a centralised point of contact with self-referral rather than relying on the current general practice setup?
I think that's interesting. I would like to see a central point. I don't know if it's going to happen. I don't know if there's any appetite within the health service to provide that. I'm not entirely sure. With regards to whether or not GPs are actually resistant, I don't know. My impression from women that I spoke to wasn't necessarily that I felt like the GPs were judging them. That's important to reaffirm, but also that they were worried about their own position. I think if we can reassure GPs that they can give advice to women, it might be that they don't disagree with abortion, it's just that they're uncertain of their own position. So perhaps by even reassuring GPs about their position, being able to give advice and information to women without contravening the law, that might help things in itself. I'm not entirely sure about general practitioners' views on abortion on the island. Again, it's never been looked at. We don't know what their current views are. And it might be that a large number of them disagree with it, but again, I don't know. I would like to see a central point of information, because some women didn't feel comfortable consulting their GPs, simply because, well, for a lot of reasons really, because they see them about other things. Perhaps on the island it's interesting because a lot of women have grown up with their GPs, so perhaps they've been their GP since they were like 5 years old. It's very difficult then to go and see a GP and say, actually no, I'm pregnant, I don't want to be. So I think there's a lot of the issues need to go on, and I think that actually going both routes, providing a central place where women can contact and get information, help and resources, but also reassuring GPs that they're not contravening the law. I think doing both would probably be quite helpful for women.
Professionally.
Have you got a quick question?
I'm amazed that you haven't talked about family planning clinic very much, but my question is slightly on this other subject of stigma, which I think is really interesting, and the guilt, if you like, false guilt or the induced guilt from stigma. Having worked in Sheffield for 20 years, I'm still astonished that so many years after the Abortion Act, so many women still keep their terminations extremely secret and feel conflicted, as Anne Robinson showed on that amazing BBC programme very courageously about her abortion 50 years ago. And I wonder whether you think just removing, if you like, decriminalising, which is what's going to happen in the UK probably, whether that will really deal with that sense of conflict which women feel naturally enough, having interrupted a pregnancy, which is such a natural process, so deeply ingrained, that desire to be a parent. Do you think that really will deal with that that sense of conflict which so many women feel many years later?
I think it will deal with some of it. So the reason being is that I think because when you criminalise something, you're saying it's outside of our society, it's something we don't want in our society. And I think if you can remove that social aspect of stigma, which a lot of stigma is social, that conflict that comes from the outside rather than internally, then yeah, I think that would help with that. I think by decriminalising, I do think that you go a long way to changing public's attitude on something. Just as you do when you criminalise something, you change the public's attitude through legislation, that can be done. In terms of the internal feelings about pregnancy and stuff and motherhood, it's incredibly complex. I don't think that every woman naturally wants to be a mother. I don't think that it's ingrained within women to be maternal. I don't believe that personally. Some women in my study said, I got pregnant, I've never ever wanted to be a mother. I never wanted children. So it felt very, very distant from them. It didn't feel like something that was in keeping with who they were. So, I think it's again down to the individual. Women have very complex emotions about the idea of motherhood, the idea of having children. But one thing that came through really clearly was the idea that having children is too important not to get right. So women had terminations because they didn't want to get it wrong. So women that maybe want children in the future but felt this wasn't the right time, that was why. And within my study, all but one woman were very, very certain straight away of the choice to have an abortion. So it wasn't actually a massively complicated decision for them, and it wasn't really that internal sense of stigma. They felt it was from the society, the stigma. So I do think in that case, decriminalisation would definitely help.
Right, I think we've finished that. I have to congratulate Becky on the research that she's done, the methodology she's used, and as she mentioned, she had to get this through the Medical Ethical Committee, and the way that she's approached it and the way she's presented it today. So thank you very much.
Thank you.